Well, good morning, everybody. Let me introduce myself. So I'm a neurologist and I'm a neuroscientist. And so that means that I see patients, and I've seen many of you actually in the clinic. I see patients with a variety of autoimmune disorders like transverse myelitis and the whole spectrum that you've just heard about from Dr. Greenberg. But at Hopkins, we also spend a lot of our time in the laboratory trying to figure out really what causes some of these things, how to treat them in the acute phase, and then what happens after the disability has already set in. And is there a possibility of restoring therapy or regenerating function after it's been lost? So I'm going to tell you about a few things today, if we can hook up my computer, which I can't use from here, so we're hooking it up in the back. What I want to take you through first is the approach to sorting among these various things that Dr. Greenberg spoke about. So in the acute phase, how can you help to distinguish one from the other? And what are the critical distinguishing clinical factors? It was there for a second. Okay. So I advance then, right? Okay. Every time I push, oh, hang on. All right, so we'll get it up, and I may go back and forth between the two. I want to talk about the people who, the forward. Yeah. Yeah. All right, so the people in the lab who have done much of this work, that is to sort out what really are the causes of transverse myelitis, how do we approach these disorders, and some of the stem cell work that I'm going to tell you about are indicated here. Tara Martinez, Deepa Deshpande. We have a whole surgical team that allows us to look at the biology of stem cells and how it might be ultimately used as a therapy for these disorders. I also want to talk about my collaborators who really do all of the work. So Adam Kaplan is here. You'll meet him. Ben Greenberg, you just heard from. Peter Calabresi runs the MS Center at Johns Hopkins, and Chitra Krishnan runs all of our lives. So these are the people who've thought of most of these ideas that I'm going to tell you about, and these are the people who've done most of the work. I want to also thank the Transverse Myelitis Association for supporting a lot of our work, giving us the ability to kind of make some of these advances. So what are we going to talk about in the next about 30, 35 minutes? One, as I just said, clinical approach to patients with acute myelopathies. In other words, somebody comes in with one of these disorders. How do you think about diagnosing them and distinguishing the various characteristics? And this is a little bit different than in your outline because I've taken out some slides in the outline. That's your homework for later, but I don't want you to get too stuck on now. So I would say don't look too closely at your outline, but rather up here, and you can use the outline for later. I'm going to talk about a clinical approach in multiple sclerosis that we're using. So some of you I know have multiple sclerosis, and we're going to talk about an evolving approach to treating patients very aggressively with multiple sclerosis. I'm going to talk about some of the work that Dr. Kaplan has done in figuring out what causes transverse myelitis, and then we're going to talk a little bit about stem cells. So let's define transverse myelitis a little bit more, and let's run through how you would diagnose it. Transverse myelitis is an acute inflammatory disorder of part of the spinal cord. It is immune-mediated. Dr. Greenberg told you that. That's what inflammation is. It's this misdirected inflammatory response that directed against the spinal cord. And so the symptoms that happen from this inflammation are in four categories. Motor, which can be weakness, spasticity, paralysis. Sensory dysfunction, which can be numbness, paresthesias, which is a pins and needles sensation, or dysesthesias, which is an uncomfortable, poorly defined sensation. Outright pain, and the fourth is autonomic dysfunction, which include sexual dysfunction, bowel and bladder dysfunction. Now, transverse myelitis fits on this spectrum because it typically is monophasic and monofocal. One phase, one attack in one region of the spinal cord, with some few exceptions that we've now learned to kind of sort between. But that's really the classic distinction between transverse myelitis and multiple sclerosis. They are indeed cousins of each other, except for that fact multiple sclerosis is multiphasic over time and multifocal, brain and spinal cord and optic nerve. Now, we do believe, and there is some clear-cut evidence, that transverse myelitis is post-infectious and involves breakdown of immune tolerance for self. So the good immune system, which is what Ben just told you about, can appropriately sort yourself from the foreign things, the infection, and would not attack yourself. But in many cases, the infection triggers an immune response initially directed against the infectious agent, the bacteria, that then goes wrong. And the immune system starts to make a mistake, and it shifts over to attacking your own spinal cord. And I won't go into the mechanisms whereby this can occur, but many of the infecting bacteria or viruses do this on purpose. I don't say that they have a mind, but what they do is their intention is to divert the immune response away from them. So it's kind of a dastardly deed because it allows them to escape eradication for a longer period of time if they can create a diversion. What's the diversion? It's your spinal cord, allowing this virus or bacteria to replicate for longer periods of time. And we now know kind of molecularly through molecular mimics or something called superantigens that that's how the infectious agent does that. Now, why would it then be just the spinal cord? If the immune system is going bad, why in transverse myelitis would it be just in a region of the spinal cord? Don't know for sure, but there are several lines of evidence that say three things are contributing. One, there's a unique injury, inflammation that triggers specifically within a region of the spinal cord. So that's where it all starts. That's the epicenter, and then the immune system kind of piles on. Two, the immune system within the blood can only get into specifically some regions of the nervous system, especially the spinal cord. So it's a unique trafficking of immune cells into the nervous system that they can't get to other regions, and that's why the transverse myelitis occurs where it does. Third, we know that the spinal cord responds differently to inflammation. So that there are unique pathways activated only in the spinal cord, and Dr. Adam Kaplan figured out a lot of this. So when I say inflammation, this is what I mean. What you're looking at is a cross-section of the spinal cord looked at under the microscope, and blue here is inflammation. Each of the blue dots represents a cell that should be in the blood that has gone into the spinal cord. This is a blood vessel, and you can see all the blue around it. There's another blood vessel, blue around it. That means the cells which were in the blood have decided to get off the bloodstream and get into the spinal cord. And we don't want them there, really. This is where they're triggering the injury. So that inflammation then results in injury to the spinal cord. So the inflammation resolves in transverse myelitis because, remember, it's a one-time monophasic event in most people. So the results of that inflammation are one of two things: demyelination, which means the stripping of the myelin sheath or the insulation around the wires, which are called axons, or axonal injury, which means the wires themselves are disrupted. So there's two things that I want you to remember. One, it's the wire itself. Two, it's the insulation around the wire. Two types of pathology which would require really two different types of treatment. So how have we gone about studying this? Well, we've established, Chitra and I did, back in 1999, the Johns Hopkins Transverse Myelitis Center, It's in October of 1999, and we established it for clinical care, but also clinical research and basic science research. And we've now seen, this is a moving target, but around 1,145 patients or so who have come to us with a presumptive diagnosis of transverse myelitis, or one of those that you heard about from Dr. Greenberg. So from a clinical perspective, we evaluate patients with multiple physician groups and healthcare providers, which includes neurology, urology, rehab, neurosurgery, rheumatology, anesthesia, neuroradiology, and psychiatry, also physical therapy, occupational therapy, physical medicine, and rehab as well are critical components of this. So from a clinical perspective, it helps us to manage the symptoms and to direct acute therapies. Now, one of the initial outcomes of developing this center is establishing a meeting which was back in 2001, bringing all the experts together, including Dr. Morrison and others, and saying, listen, we've got to decide what is transverse myelitis and how do you sort it out from these other things. Greg Barnes was there, and all of us co-authored a paper which has now been in the medical literature since 2002 and does exactly that. Now, I'm not going to go over these criteria, but it says to the practicing a physician or healthcare provider, these are the things that you would see, these are the things that should make you suspect this, and what I'm going to show you is it also suggests a treatment strategy, a treatment tree, and we're going to go over that. So the other thing that this criteria allowed us to do is to sort out transverse myelitis from transverse myelitis associated with some rheumatologic disorder like lupus. I'll switch over here for now. From that associated with Devick's disease or neuromyelitis optica. From that's associated with a direct infection of the spinal cord, or even multiple sclerosis. So this criteria set allowed us to parse among those various things. And I want to walk you through kind of how we do that. So this is now kind of where we are. And again, this is an approximation. This is a moving target. Chitra is putting this together more, but essentially over 1,000 patients that we've seen, and we divide them among these various groups. Do they have, first of all, a compressive myelopathy or something pushing on the spinal cord? Because that's not a myelitis at all, right? That's something pushing on and squishing the cord. Itis is inflammation, right? So that's different. So then there are non-compressive spinal cord disorders, but there's no inflammation. There are other causes. For example, a spinal cord stroke. That's not really an itis, right? That's a stroke. That's losing oxygen to the spinal cord. So that's a different type of thing. And then you've got this whole variety of inflammatory itises. And those are infectious or associated with a rheumatologic disorder like lupus, or the other ones that Dr. Greenberg told you about. So this gives us a framework to sort between them. Here is this diagnostic tree. So this has been now published in the medical literature since 2002. It's in your handout. And what it basically does is it walks the practitioner through how to evaluate a patient who comes to the office with something that looks like an evolving myelopathy. And I'm going to break this down. So I don't need you to look at it here because we're going to break it down and run through it kind of quickly. Step one, is it a spinal cord problem? Somebody comes with numbness, tingling, weakness, bowel or bladder dysfunction. The first step, is it the spinal cord that's being involved? And so you've got to do the history and the physical examination. You've got to make sure that it's not, for example, a peripheral neuropathy, a pinched nerve, one of these other things that Dr. Greenberg mentioned about. So this is done really by history and physical examination and says, yes, indeed, whatever this is, it is a myelopathy. It's a spinal cord problem. Okay. So again, how does that present? Any myelopathy can present this way. The 4 symptom groups that we've talked about. The weakness can be very subtle, all the way to complete paraplegia, which means you can't move the legs, or even quadriplegia, where you can't move the legs and arms. Legs are usually involved greater than the arms, although in certain cases, the weakness can be mostly in the arms with some sparing of the legs. Tone is something that you may hear the healthcare providers talking about. If somebody is trying to put their muscles at rest and instead the muscles are stiff and can't relax, that's really a sign of increased tone, and that's something that is very common with any spinal cord disorder, any myelopathy. Sensory, again, paresthesias, which is a pins and needles sensation, numbness, warmth, burning. And what should be done in the evaluation of this is you've got to take the little pinprick and you've got to see if people feel that as a sharp object. Because in many people with transverse myelitis, at a discrete point, it changes. That pin is sharp on top, and then at some point it changes to being not sharp at all. And that's the level of the injury in the spinal cord. And as a result, the sensory nerves that come in below that don't convey information to the brain. That impulse doesn't get there, and as a result, it doesn't feel as sharp. Now, bowel and bladder dysfunction is virtually universal in myelopathies, which again is any spinal cord disorder. And many people have urinary urgency, which is really decreased interval from bladder fullness to evacuation. All it means is when you get a sense you got to pee, you got to get there quickly, like seconds in some cases. And all that means is that the bladder is doing the only thing it knows how to do when it's full of urine is to start to contract. And the urgency that the patient is feeling has to do with the bladder actually contracting. What normally happens in somebody who doesn't have a myelopathy is you can inhibit that. So your brain says, no, I'm listening to a really cool lecture, and I'm not going to the bathroom right now. In somebody who's got a spinal cord problem, you can't do that, and so the bladder does the only thing it knows how to do. That's urinary urgency. In some cases, it's the other side. It's retention. You just can't pee, and you try, and you try, and you try, and it won't come out. Bowel urgency will be often the same. Sexual dysfunction. It is more common with transverse myelitis than it would be, for example, with an extrinsic spinal cord compression, such as a disc herniation. Finally, pain, as many of you know, is a big factor in this, and it persists for a long period of time. Those nerves are irritated, and you have pain nerves. You have nerves that are there to protect you if you have your foot on top of a stove that's hot. I don't know why you do that, but the pain fibers are to protect you. But when the pain fibers are irritated and demyelinated, they fire anyway, even though your foot is not on the stove. And so that's where this pain comes from. And it can be burning, it can be in a particular distribution, it can be a squeezing or banding sensation, and it can be agonizing, as many of you know. Okay, so that's how we've decided that this is indeed a myelopathy. It's something wrong with the cord. The second step is it something pushing on the cord? Okay, so for that you need an imaging. You need something to look at the cord. Dr. Greenberg showed you the MRI. That's the best way to do it. And you can see if there's a disc herniation or something like that that is actually squeezing the cord from the outside. Why is this the next step? Because it's really important, because something can be done about it and should be done about it in hours. You got to remove whatever the thing is that's squishing the cord, because squishing the cord is bad, right? So that's why this is so quick, and that's why you need an MRI of the brain in the acute phase quite quickly. So this should be, until this point has been decided, should be really construed as a neurologic emergency. Now let's say that it is not compressive, that there is no disc herniation or tumor or something like that. Now you've got a spinal cord, a myelopathy, but you don't know the cause. So the next step, step 3, is it an itis? An itis is inflammation, right? So is it an inflammatory cause of the spinal cord not working? And so for that, you need your MRI again, and you need a lumbar puncture. And the spinal tap or lumbar puncture looks at whether or not there's those cells, the inflammation in and around the spinal cord. And so from these criteria, there are clear-cut imaging and spinal fluid characteristics which say yes or no, this is an itis or it's something else like a spinal cord stroke. Okay. Now, if it looks to be non-inflammatory, we've got to think about a series of things that can cause that. You may have to repeat the spinal tap in 2 to 7 days. And in your handout, there's a whole table which goes into what are the various types of non-inflammatory myelopathies. If it's not something squishing the cord, and it's not inflammation, there are a series of things that can cause the spinal cord to act incorrectly but are not inflammatory, such as the spinal cord stroke. Those are present in your chart, and I don't want to go through them now. Okay, so let's say it is an itis. So it's inflammation. So now we're at transverse myelitis. But Dr. Greenberg told you a whole bunch of other things that can look like transverse myelitis, ADEM and NMO and MS. Okay, so you still got a few tasks left. One, is it an infection? Because infections, herpes viruses and other things can directly infect the spinal cord and would, of course, require different treatment. Two, is it associated with systemic inflammation, or in other words, a rheumatologic disorder? Lupus would be the big one. So is lupus a part of this? And to the question that was asked after Ben's talk, so can it present with fevers, chills, night sweats, people feeling and looking really sick, rashes on the skin? Yes to each of these, right? If there's an infection, yeah, you can have fevers and chills and night sweats. That's something we need to know about. And if it's a lupus flare, that's what lupus can look like: a rash, fevers, chills, night sweats. So yes, we have to know that. And then finally, where is it? Now you've got an itis, it's in the spinal cord, but is it just in the spinal cord or is it elsewhere? So this is where you say, all right, listen, if it's only in the spinal cord, it's transverse myelitis. If it is in the optic nerve and spinal cord, it's Devick's disease. And if it's all over the place, it's multiple sclerosis or ADEM. So now you've been able to sort among compressive myelopathies and various kinds of spinal cord disorders that are either inflammatory or not, and then the various subtypes of transverse myelitis and multiple sclerosis. Now, this can be the first presentation of what will ultimately be defined as MS. And in some cases, you can get a history, even at that first attack, that there were previous attacks for which the patient did not seek medical attention. So sometimes you get the history, even at the get-go, that there was a previous attack, like an optic neuritis attack. But beyond that, imaging characteristics. So the MRI can tell us between, for example, transverse myelitis and multiple sclerosis. The irony is that if it's ultimately going to be multiple sclerosis, the first attack is usually very mild. It's irony because in multiple sclerosis it will recur, but each attack is usually pretty mild. Whereas in transverse myelitis, it's usually only one attack, but it can be a whopper. There are other things as well. Oligoclonal bands, which is a spinal fluid finding. You always have to get the MRI looked at. If somebody presents with a myelitis, you've got to look at the brain, even though they're not showing any symptoms in the brain, because that's a critical distinction between transverse myelitis and MS. All right, so I'm going to shift to a few other things to tell you about not the clinical management, but what have we done to understand this disorder a little bit better. So this is work really led by Adam Kaplan, and it talks about this protein called interleukin-6, which really is that biomarker that defines transverse myelitis. Because when we started looking at transverse myelitis, we said, okay, there's something that makes somebody susceptible by their genes and something in the environment that then triggers things, and then people get TM and often depression, which Adam will talk about. But between those points, we had no clue. So we wanted to understand that a little bit better, and Adam did a series of studies where he looked at the inflammation. I've been talking to you about inflammation, but Adam really looked at it. And he found that in the spinal fluid of these patients, consistently, one protein was there and only in transverse myelitis patients, and it's this protein called interleukin 6, IL-6. And when he did this on a bunch of patients, he found that it was elevated in most of them, and it was just about the only thing elevated, unlike what you see in, for example, MS, when there's a bunch of things elevated, or even traumatic spinal cord injury, where there's a lot of inflammation, but a lot of different types. Not here. So that was very intriguing to us, that one, it could help diagnose transverse myelitis by this simple marker, but two, could it help us understand how to treat it? Now, I'm not going to go through what interleukin 6 is here, except that we know from other literature that it can be bad for you. So it was then logical for us to think, if it's bad for you, as we know it is, for example, in the heart, maybe it's bad for you in the spinal cord. So Adam then did a bunch of other patients with a variety of disorders, including transverse myelitis, and he found that it was elevated to the level of 516 picograms per mil. Everybody remember that? No, I'm just kidding. But just to let you know, normal is about 2 picograms per mil. So it's really elevated. And it's a little bit elevated in multiple sclerosis. And I'm going to skip this except to say that patients came in with transverse myelitis with varying levels. And what Adam found out is that if somebody came in the acute phase with a really, 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 really high level, they didn't do very well. They did not walk again. If somebody, by contrast, came in with a very low level of IL-6, even though they looked the same in the acute phase, they did quite well. So it's a prognostic marker. Now, we're in the process of extending these studies further, but this was very intriguing to us because when you look at patients in the acute phase, you can't tell by the MRI, and you can't tell by the clinical whether they're going to recover or be in the group of transverse myelitis patients who do not recover. And this helps in that. Adam then did a cruel trick, which is to actually create a rat model of transverse myelitis. Mean. And he did this by infusing interleukin 6 into a rat. And guess what? The rat got weak. And as sad as we were about that, we were excited because it allowed us to model transverse myelitis and to develop therapies. So what you're looking at is the grip strength of a rat, a bunch of rats actually, getting weak, as Adam has infused this interleukin 6 into their spinal fluid. And when he looked at their spinal cords, it looked very much like transverse myelitis. There was, remember the two pathologic features of transverse myelitis? I said it earlier. Axonal injury and demyelination. Adam showed both are present in the rats that got IL-6. So we really kind of made the disease that looks very much like human transverse myelitis in the rats. So I won't show you the data, but Adam then went back and said, okay, well, we know kind of what triggers the injury, and now we think we can block it. And so now we've kind of filled in these boxes, right? So it used to be genes and the environment, trigger, and then all this stuff. But now you've got a bunch of the factors that are involved in actually creating the demyelination and the axonal injury. And as a result, there are potential therapies now that emerge. That's what this research does. Things like thalidomide, erythropoietin, statins, minocycline, others that are in development now will address this pathway and may be appropriate clinically for patients getting transverse myelitis in the future. Okay. I just want to shift to an MS clinical trial. This is new data, and it's what we have done for patients with aggressive MS. Patients who have had MS, and I know there are MS patients here, which is why I wanted to tell you a little bit about our approach to this. It's called rebooting the immune system. This was not in your handout because we didn't have this data when I submitted this. This is all new. So this is hot off the press. The problem in MS therapies are only modestly effective, and there are some newer therapies, but they pose significant and to some degree undefined risks. We don't know kind of what the long-term risks are of some of the new therapies. And even on the best current MS therapies, patients continue to accrue disability. That means they continue to get worse. So if you take Tysabri or natalizumab, which is a very powerful approach to treating patients with MS, patients still tend to get worse over time. In one critical study, 17% increase in their level of disability over a 2-year period. So therapies also must continue indefinitely. So as long as you got MS, which is for the rest of your life, you're going to have to be on treatment. So there are few potential solutions. One of them is very, very aggressive, which is basically immunoablation, which means you get a whole bunch of chemicals to knock out your immune system, and then you transplant back into your own body your bone marrow that has been depleted of T cells, the bad guys. It's called autologous stem cell transplantation. Several groups, Seattle is doing this, Northwestern is doing this, and McGill in Montreal is doing this. And it can be very effective, but it is a big, big deal, and I'll show you why. We have another approach, which I want to share with you, which we're calling rebooting the immune system without transplantation, which has been exciting so far. So hematopoietic stem cell transplantation can be very effective and leads to clinical stabilization in about 75% of people. The MRI looks good. So we use the MRI in MS to assess disease activity, and it looks good. The number of plaques go down, the number of active lesions go down. The problem is the brain may, to some degree, continue to atrophy, and that may be because of the regimen needed to knock out the immune system can be pretty toxic. There are risks of this approach, including the most of which is a mortality of up to 5 or 10%. That's not good. So, although this can be a very effective strategy, and it is one which says, listen, the immune system has gone bad, let's just make it new. Let's give it a take two. Your second approach at the immune system, and it won't be autoimmune anymore. It will appropriately know between yourself and the infections that it needs to fight. The idea is good, but the toxicity may preclude its use. So we've developed an approach which is called, it's Revimmune is the name of the drug. It's immune ablation without transplantation. And this is just a 60-year-old drug called cyclophosphamide given in a particular way that basically allows the immune system to be reconstituted, but without needing transplantation. So this dose of the drug eliminates mature and maturing immune cells, so all of the guys that have gone bad of the immune system are wiped out. But the bone marrow stem cell is resistant to this dose of the drug. It is not killed. Why? Because it has an enzyme in it called aldehyde dehydrogenase, which means it detoxifies the drug. So that's cool, because now the bone marrow stem cell, which is spitting out a new immune system is able to start its work. So the immune system then reconstitutes from that patient's own bone marrow. It's as if your computer has gone bad and you've had to just reboot it. In this case, your immune system has gone bad and you got to reboot it. The advantages, well, it's effective in eliminating mature white blood cells, but it doesn't damage the patient's own marrow stem cells. It's less risky, so we don't need those harsh, severe treatments used for the transplantation protocols. Unlike hematopoietic stem cell transplantation, peripheral blood cells are not reinfused, no risk of infection or contamination. It's much lower cost as opposed to the transplantation, which is about $300,000 per patient in the first year alone. This is about $30,000. And the mortality is much lower. It's probably even lower than 0.5%, which means even 1 in 200. We've not had a patient die as a result of this approach. It is aggressive. It's not for everybody, but it is much, much safer. So let me show you what we do. We give this drug at a certain dose. It's actually 200 milligrams per kilogram per day, and they get a bunch of other things around the time. It's a treatment given up front for 4 days, and then you're done. They get this drug to stimulate, called GCSF, to stimulate the bone marrow to recreate your immune system again, and that accelerates it. And then a week or so later, maybe 2 weeks, the immune system is recreated. And once that happened, the risk is over, because you've now got a new immune system. Interestingly, that patient is no longer immune to the childhood immunity for which they've been vaccinated. You have to revaccinate people, which does indeed mean that you've created a naive new immune system, right? Now, there are side effects. This is not for everybody. This is an aggressive approach. People get nausea. They get balding. It's transient. They get blood abnormalities, white blood cell abnormalities. You have to re-immunize. Initially, people got herpes zoster, although that's shingles. That doesn't happen at all anymore. Very few people get febrile neutropenia. That means they get an infection when their immune system has not reconstituted. That's the thing we're scared of. And for that reason, people go on antibiotics when they get this done until their immune system kicks back in. So we've treated 9 patients. Chitra has led this study, and I'm going to just summarize what we found. We found a marked decrease in MRI lesions, clinical improvement, so not just halting disease, but actually making them somewhat better in some of the people. And it was better if patients got into the trial at an earlier stage of the disease. So here's what happens to the white blood cells. Here's where you normally are, and then you get the drug, and it drops. And for this week, that's when you're on the antibiotics and the viral medicines, because your immune system is not good at all here. After it reconstitutes, then you're okay. You go off of the medications. So what happens when we look at each of these patients over time? Now, I'll just tell you that we selected the absolute worst of the worst of the worst MS patients, very active, aggressive disease. So all of these people were getting more and more disability. Disability here is called EDSS, and the higher you go, the worse you are. So these people were on this bad course where they were climbing up despite being on conventional therapy. They got the drug here, and then we follow each of them for now up to around 32 months. And a few of the patients stayed fairly stable, maybe got a little bit worse, but many of them actually got better with lower levels of disability over time, which was very exciting to us. And this is where I came up with the the statement I made previously, that the earlier stages of the disease, when you have a little bit less disability, are more likely to actually recover some function. And we can look at a more global score of disability. It's called the MSFC. And I'm not going to go into this except to say that in terms of cognition and upper extremity strength and lower extremity strength, virtually all of the patients had improvements. Now, we worried about brain atrophy, or the same thing I told you about happened in this transplantation group, which was that the brain shrinks a little bit. So if you look at one patient here, this is the time at which they got their treatment. There is a little bit of brain atrophy over the next 6 months, very little. And yet in this other patient, there was actually an improvement in brain volume. So it's small numbers, but it suggests to us that the same thing that is kind of toxic in this other approach is not there here. There may be in few patients, hang on one second, a little bit of brain atrophy, but it doesn't seem to be common. Okay, so the conclusions then, and then I think I'm going to stop and take questions. I probably won't get to some of the other stem cell things, although I could probably talk to you about it later. Revimmune is safe and induces rapid and sustained clinical and radiologic improvement. Patients with advanced disease continue to have progression of disability, while those with early disease have an improvement in function. And we are now planning for a phase 3 large-scale, multi-center clinical trial to look at this in patients with early multiple sclerosis. So I think my time is probably up. Is that right? So let me just stop and take questions. Yes?
Can this procedure regarding MS, although I don't have that, I have the TM, but can this be communicated to a physician of a person who has MS so that they can be treated wherever it is that they live?
So the question is, could this approach be used for MS patients now, elsewhere, at some place other than Johns Hopkins? The answer is yes. It requires a really integrated team because the acute phase of this treatment is a big deal. So you've got to watch these people really, really carefully. Now, so it can be done now. There's no reason why it couldn't. But it has to be done very, very carefully. We at Hopkins are continuing to offer this to selected patients. But then more importantly, this clinical trial will begin probably within a year and will enroll patients throughout the country at various sites that have yet to be determined. Question? Yeah?
What happens if someone with MS unfortunately gets HIV disease? Do they sometimes get a partial remission of the MS?
So if somebody gets MS and HIV, what happens to their multiple sclerosis? I haven't seen that much of that, but we've seen a couple cases. And in fact, unfortunately, the MS in those cases actually got worse. And the reason is that in the early stages of HIV, the consequences are not really the result of profound immunosuppression, but a derangement in the types of immune cells there. So there's a shift in the populations away from the appropriate kind of regulatory T cells to the activated killer cells, so the MS can actually worsen. It would, however, maybe guide what treatments you use, because you wouldn't want to, in that unfortunate patient with both, globally immunosuppress them, right? Because you would probably accelerate the development of AIDS to further immunosuppress them. Other questions? Yeah?
As you move from, in transverse myelitis, as you move kind of the initial phase, is there any change in pain symptoms?
Yeah, the pain symptoms in transverse myelitis will evolve over time, but they evolve in very distinct ways for individual patients. One classic scenario is pain wasn't there in the acute phase, and instead what was there was numbness. So numbness really is the lack of these sensory nerves conveying their information up to the brain. As the inflammation resolves, those sensory nerves now start to fire again, but they fire abnormally, creating pain. So that's the most common scenario, is that the pain actually develops after the acute phase. And in many cases, that's good, because it says things are waking up. But in some people, it doesn't resolve. The sensory nerves never adapt and are always irritable and always fire. And so for those people, we need treatments for neuropathic pain.
Is there any new treatments for that?
Are there any what?
I have transverse myelitis, and I have pain from the very beginning. It just started to where I couldn't, it was getting hard to walk, and then it was just like I've been third-degree burn from here down. And is there any new pain medicines for that?
Well, so it's a complicated question, but how would you treat pain? I mean, it's a whole lecture in and of itself. Are we done? You want me to?
Well, I have an announcement.
Okay.
So when you're done with your answer.
Okay. So this needs to be addressed in a very active way because there are a series of graded approaches to neuropathic pain. And it starts with some of the old medicines, Elavil, nortriptyline, Neurontin, newer medicines, Lyrica, combination with physical therapy, acupuncture, massage, spasticity reduction, on up to intrathecal medicines, neurosurgical procedures. So it starts kind of low level, and it's a very active, ongoing process that has to be, done over time. So I would say you got to work with somebody who knows pain and says, listen, we can treat this, and goes through those steps of hierarchical involvement to treat the pain.
Thank you, Dr. Kerr.
You're welcome.
This is Clarissa. Clarissa's 4 years old, and she's one of my patients with transverse myelitis, and she has an announcement to make.
Time for snack.